All right, so we have a 70-year-old female who basically presents with a few weeks of abdominal pain radiating to the back. She denies any nausea or vomiting, and the ER calls you saying she has had some lab workup that demonstrated elevated inflammatory markers and a positive ANA. So a SED rate is 100, CRP is 12 milligrams per deciliter, and the ANA was 1 to 2560. So what additional information would you guys like to know about her history?
I guess I'll start us off by saying, I guess since I've been on the ID service for a while, for a couple of weeks now, that typically when I see ESR-CRP, I think, okay, we're thinking inflammation. But once I see the ANA, I'm thinking, oh boy, this is something a little bit more sinister. So, I guess we could start off. Pain radiating to the back seems a little bit interesting as a presenting symptom. I probably would have talked with her a little bit about if she's had any sort of joint pains or rashes or fevers, anything sort of markedly inflammatory that would explain that that high ANA. So I guess that's where I'm beginning. And yeah, same again. I'm curious why we even got an ANA in the first place. ESR-CRP, maybe I would have understood, but like, is she having fevers? Did she get cultured? Did she get blood cultures for any reason? That's sort of my beginning thoughts.
My thought is this is really high ESR and CRP, so this patient may have inflammation in her body. ANA is very high with the high titer. It's a decay that the patient have maybe have a autoantibody with a high concentration in her. And when look at the the chief complaint, this is this is old female, and now she didn't have a typical lupus lupus manifestation. So I wonder why what is come to wrong to her diagnosis. Yes, and I want to know about the history. Is that actually her medication? Any medication can cause lupus, like isoniazid or rocanomid. Otherwise, past medical history about her liver disease or tuberculosis, TB and I want to know her about the miscarriage, the past medical miscarriage in her past medical history, which maybe indicate a previous lupus. Yes, and this is my thought now.
So happy to fill in with some of those details. I think you guys had a good initial discussion. So a couple of people asked about, history, sort of like a rheumatic review of systems and other history questions. So you had mentioned, I think, fevers. She denied any fever. She does report history of dry eyes and dry mouth. She says she's had multiple sinus infections in the past, but never had like bloody drainage or nasal crusting. And then she has had a history of a rash in the past. She says it was biopsied and she was told it was skin lupus, so some type of cutaneous lupus, but She says she would get lab work with her dermatologist, and she never had any signs of actual systemic lupus. And she denied joint pain or joint swelling, alopecia, nasal or oral ulcers, and she did endorse a history of Raynaud's. And then I think the other question someone asked was about past medical history. So she had this history of cutaneous lupus, a history of diverticulitis, and hypertension. So with this information, we can see if you guys have any other thoughts.
This is Angelo Gaffo. I was invited to discuss some aspects of the case as I'm a rheumatologist. Thanks for inviting me first of anything. And I was very amused when I was looking at the comments in the chat, because it's exactly what I was considering in many ways. After the first sentence on the introduction, I was initially taken by, why do you check an ANA in someone that has abdominal pain radiated to the back? And it's very important to put the ANA test in the right context. It's a test that is very, very, very poorly specific. And even in high titers, it's very poorly specific, meaning that there are many reasons why people can have elevated ANAs. And it will not point you in the right direction, and actually can deceive you a lot unless it's checked in the right context. For example, someone who has a malar rash, young woman with malar rash, and an active urine sediment, an ANA is highly valuable, as opposed to someone who is a middle-aged man with back pain, with is degenerative, that gets check an ANA. In that case, the ANA is not going to help you. Probably it can be positive, but it's going to be meaningless. So it's quite interesting that in this case an ANA was checked. Now that we have a little bit more context, we understand better. This patient has had a history of what seems to be cutaneous lupus, and lupus can come into flavors. Sometimes once cutaneous lupus tends to be a cutaneous only disease that includes discoid lupus, and sometimes the other lupus that is called subacute cutaneous lupus, that is a more erythematous photosensitive rash. And it's said there that there was in the past never evidence of systemic lupus. So this ANA could be related to her cutaneous autoimmunity. But there is also mentioned that there is dry eyes and dry mouth, so opening the question of whether this patient could have Sjogren's syndrome. Now, both of these options, cutaneous lupus and Sjogren's, do not kind of link very well with what the reason why this patient is presenting, that is several weeks of abdominal pain radiated to the back. Now we know this patient has a very elevated sedimentation rate and a very elevated C-reactive protein. Whether the cutaneous lupus is turning into some more systemic autoimmunity, explaining this, we still don't know. When I think about someone this age with abdominal pain and very high sedimentation rate and C-reactive protein, I think about the possibility of giant cell arteritis with aortitis. And I think about the possibility of sometimes IgG4 related disease that we're seeing more often now, or it could be a malignancy like a lymphoproliferative disorder or a lymphoma. So those are my opening comments from the point of view of just the labs. There's a lot to unpack still here.
Great, yeah, those are great thoughts that you had. Any other things that you guys would like to know for the history? I'm happy to explain why the ANA got checked as well before we move on. But
I guess if we're going along the lines of something like a giant cell arteritis, did she complain of any headache or loss of vision or blurry vision? did she have any other again, talking a little bit about is she having like any rash or any rash now as opposed to in the past? I'd want to get a set of vitals to see if she's hypertensive or something like that.
So good question. She denied any any history of headache, vision changes, jaw claudication. So those would be things we would think about with GCA. And then you had asked about, what was the second part again?
I just want to get a
The
set of
hybrid
vitals,
vitals.
yeah.
Sure. So she's afebrile, heart rate 76, blood pressure 121/42, respirations 19, and satting 99% on room air.
It's important to know that patients who have a giant cell arteritis, which causes aortitis in the thoracic aorta or in the abdominal aorta, might not have any cranial symptoms. So you remember giant cell arteritis as a disease that commonly causes headache, jaw claudication, blurry vision, double vision, and that's true. You know, that's a very common presentation when the vascular bed involved is the vascular beds are in the head and neck. But you can have isolated disease isolated, to the abdominal or thoracic aorta without involving the cranial nerves. So I just want to give that comment, but I will also have asked about headache and jaw claudication because sometimes it can be in both vascular beds. Yes.
And the fact that she's 70 years old kind of takes a couple of things it sort of lowers a couple of other things down the differential, things like Takayasu arteritis, which if I remember correctly, usually like the patient population in that disease is quite younger, probably on the order of like 20 to 40. So, and I guess the other thing is that I think that's all that I'm pretty much thinking right now.
And you know, I think that's a good point, thinking about her age, right? Because you know, Dr. Gaffo has probably seen occasionally patients with lupus can present in later ages, but 70 is definitely would be kind of very, very atypical on the older side. So
we have seen patients with lupus presenting quite old. Usually when older adults present with lupus, the presentation is usually characterized by joint pain, rash, weight loss. It almost looks like a fever of unknown origin in many ways. So it can be quite deceiving too. So this is a possibility that she could have just systemic lupus. Although I still have a problem if the dominant symptom was abdominal pain to call this lupus, but could be.
So we can see if there's any other thoughts you guys have. We can move on to her physical exam. About any other questions before we move on to the exam?
Yes, I have question about her medication.
Sure.
Yes, and did she have a both surgery? She had a surgery before and using an IV drug.
Sure. So in terms of her medication history, she takes Norvasc 5 milligrams, atenolol 25 milligrams, and Prilosec. In terms of her social history, she does not smoke cigarettes, drinks alcohol, 1 glass of wine every 1 or 2 weeks, and basically worked as a school teacher. And then surgical history, I think you asked about. She's never had any prior surgeries.
Thank you.
Any family history? I know it's still kind of old to again, she's old enough that pretty much anything could be on the table, or there are several things that could be on the table, but any history in her family, whether parents or children who have autoimmune diseases of any kind?
Always good question to ask. So no family history of autoimmune disease. And she said her basically father had diabetes and heart disease, mother had hypertension, and what sounded like osteoarthritis. Basically no autoimmune disease in the family.
So I guess one of the things we had kind of mentioned a little bit earlier is kind of the context. Could we get a little bit of the backstory about how she got this ANA check this time?
Sure. So she basically presented to an outpatient rheumatology clinic visit. And at that point, she had gone to this emergency room with some of this abdominal pain. And so really it was because of the history of cutaneous lupus that she had, the ANA checked in that sort of context. So I think Anne-Marie put in the chat some nice differential for ANA positivity. I think we have those added on our differential here as well.
I think at this point, we'd probably want to start, at least I would start running sort of the full gamut of the more specific antibodies that would be associated with diseases that tend to run ANA positive. So things like anti-double-stranded DNA for lupus, anti-SSA, SSB for Sjogren's, and she's had dry eyes and dry mouth. She hasn't had anything that makes me indicate that she has scleroderma or anything that would make me want to check, like an SCL70.
My suggestion will be to kind of wrap the progress of this workup around the clinical presentation and then try to fit in the labs. So right. I'm still kind of confused about how the labs fit in how she's presented. So the only thing we know about the abdominal pain is several weeks and no nausea or vomiting. Would like to know if this abdominal pain has been increasing in intensity, of course, the radiation location, the characteristics of the abdominal pain. I assume we're going to examine her pretty soon, and we're going to examine her abdomen. We're going to look at those rashes. I think that's going to help us about how much more money we're going to want to spend in the autoimmune workup. We may not need to spend a whole lot, and it may be more focused on the problem of the abdominal pain.
Right.
So sure, we can go through that. So she basically had developed this acute abdominal pain. It wasn't related to eating, and it hasn't been increasing in intensity over the last couple of weeks, but it sort of comes and goes and then occasionally radiates around the sides and to her back. So she hasn't had any significant decrease in PO, and we, I think mentioned no vomiting or diarrhea, and really no associated nausea. But she did go to the emergency department, for this pain, and then, is basically then saw the outpatient rheumatologist in follow-up because of the inflammatory markers and this history. So she was seen as a new consult. So that's a little bit about her pain, and I could go into her exam if you guys want to hear more about her physical exam. All right, so In general, she's in no acute distress. She had no cervical or supraclavicular lymphadenopathy. On her neck exam, there's no carotid or supraclavicular bruise. She has no oropharyngeal lesions. Her parotid glands are not enlarged. Her lungs were cleared auscultation bilaterally. On cardiac exam, she had a regular rate and rhythm, no murmurs, equal and symmetric distal pulses. Her abdominal exam is actually pretty benign. It's soft, non-tender, no masses or hepatosplenomegaly, no rebound. And then her skin exam, she has a couple of erythematous papules, as well as these like fluid-filled vesicles, and there's a little bit of erosion on the side with an erythematous base. And then her neurologic exam, she has no cranial nerve deficits, and strength is 5 out of 5 throughout all extremities. And her musculoskeletal exam, she doesn't have any effusions or evidence of synovitis throughout any of her joints. Does the physical exam sort of change how you guys are thinking about her case and
Just to
what could be going
clarify,
on?
where is the rash? The papules and vesicles.
So it's going down sort of the posterior thigh, but she says she has some on her buttocks as well.
Is the area around the rash painful at all? Sensitive, or is there pain related to it?
It's not painful.
So yeah, Dr. Gaffo, kind of how has this helped you? Or I guess one other thing is, in the emergency department, did they get like a CT scan? And did they see anything on that? Or did they just kind of try like PPI and outpatient follow-up?
Yeah, we can go into some of the imaging. And this will give you guys a little more context into sort of some of the labs. We just wanted to present it initially without giving you the CT imaging findings. So when she went to the emergency room, her CT abdomen showed some hazy stranding in the para-aortic fat surrounding the abdominal aorta, with prominent wall thickening and enhancement of the outer aortic wall. So there was concern for an acute aortitis or a large vessel vasculitis. And based on those findings, they referred her to rheumatology. They did check inflammatory markers, so those were the SED rate and CRP that we mentioned before. And so when she got seen in rheumatology clinic, because of the subacute cutaneous history, lupus history, he checked the ANA and repeated the inflammatory markers. So I can pause there and you can see what you guys sort of think with the CT abdomen, pelvis with contrast, sort of what comes to mind on your differential now.
This is a common problem for us, a stranding or peri-aortic inflammation being found on CAT scans, and what is the differential for that, and we depending on the location, if it's upper abdominal aorta or lower abdominal aorta near the pelvis or the retroperitoneum, it may be part of what we used to call retroperitoneal fibrosis sometimes, and the differential sometimes includes this new condition called IgG4 related disease that we are finding more and more often. That the differential also includes lymphoma. And we have seen a number of cases of syphilis presenting as periaortic stranding and inflammation. Giant cell arteritis should still be in the differential, although usually there's not a lot of stranding of the fat. It's more a vessel wall problem when it's giant cell arteritis. Now, it's interesting about now trying to, again, put things together, this rash. We need to try to figure out this rash. And I'm resonating with a lot of the comments in the chat about the possibility of this being zoster. Every time I see an erythematous rash with vesicles, I need to try to clarify that. So whether this is related to the findings of the CAT scan is still also to be determined.
But I think the other thing, Dr. Gaffo, is that there was the clarifying question of whether or not the rash was painful, and it didn't seem to be. And even though the rash is going in a sort of dermatomalish distribution, which, that sort of made me think at first, like, is this all syphilis? Or not syphilis, sorry, is this all shingles? But now I'm starting to think, is this rash more of an autoimmune rash, something like a dermatomyositis? And again, chat comes through and they sort of have my thoughts before I do. Is this something that might be perineoplastic? And especially considering that she is at the right age where malignancy and perineoplastic conditions can manifest.
This is a rash that may need to be scraped or biopsied in order to obtain more clarity and whether it's related to the underlying disease. We have seen cases of actually zoster causing a vasculitis and aortitis. Is very well described. So we need to explore more this rash.
Yep. So I think those are all good thoughts. I think next we can move to some of the laboratory testing and see what you guys would want sort of related to the case and what we know so far. And then we can get back to the rash as well in the context of the lab findings. So I think Dhruv mentioned he would want a couple of more specific labs. So you can let me know what those are, and we can go through what some of her serology showed.
So I think I started off with looking a little bit more at like the specific tests, things like anti-dsDNA, anti-SSA, and SSB were the three that I sort of started off with. But and I'd probably also want either an RPR-VDRL or whichever method you use to test for syphilis. Just to, because again, syphilis can masquerade as multiple different things. And also probably scrapings of the rash as well, or varicella IgG, just to see if this could be zoster.
Okay, great. So she did get a varicella PCR scraping and it came back negative. The syphilis testing was negative. And then she had an ENA panel with positive SSA and SSB. Let me see if I can get the titers, but I don't know if I had written them down. But they were definitely very positive, SSA and SSB. And then she had a double-stranded DNA checked. I think you asked for that. So the double-stranded DNA was normal. And then she had complements checked. C3 was normal and C4 was less than 1. So those were just kind of because of that, how high the titer of the ANA and this cutaneous lupus history, just to sort of see what those labs showed. And then her, is there anything else you guys would want to know with the complement being low, the positive ANA, any other labs or studies?
For me, it's always very informative to know the routine labs. Like if you give me a CBC with differential
Yeah.
and basic chemistries, they are usually quite informative about the other aspects of the disease.
Yeah, great. So her CBC white count was 8, hemoglobin 8.9, and it was normocytic with an MCV of 84, and her platelets are 83. And then her LFT, or her creatinine was 0.6. The remainder of her BMP is unremarkable, you know, and LFTs, her AST 20, ALT 16, ALK phos was 78, her albumin was 2.4, and total bili was normal 1.2.
And this is there are some points of interest here. With that CBC, she has a normocytic anemia. I would have expected her platelet count to be elevated. Many of you might know platelets in the context of active inflammation tend to go actually up. We see this inflammatory thrombocytosis. She has a mild to moderate thrombocytopenia, which makes me think whether there is a process, there is some process leading to thrombocytopenia because she has an enlarged spleen or liver, or there is some autoimmunity against the platelets. So I will be interested in knowing that. She has hypoalbuminemia, which speaks of this process being chronic. So there are some, again, interesting points in here. The low complements speak of this is an immunologically active process, and now with a elevated ANA, the dryness, the low complements, I think this is starting to, in the background, look more like an active autoimmune process, very similar to Sjogren's syndrome. And Sjogren's can lead to a specific type of autoimmunity with complement activation, sometimes with the presence of cryoglobulins in the serum. That is something that I would like to check now. And sometimes leads to an abnormal immune activation and polyclonal, or sometimes even monoclonal expansion that can end up with a lymphoma. And I'm wondering if that's the reason why we are starting to look at this stranding in the aorta could be a lymphoma secondary to a Sjogren's syndrome.
So I think those are all great thoughts. A couple of things from the other labs people have asked in the chat. So an HIV was checked and negative. And then the urinalysis, she didn't have any red cells or white cells, but there was trace protein, and so that did get quantified at 660 milligrams per gram. And then Dr. Gaffo asked about cryos. So because the C4 was less than 1, she had these sicca symptoms. We thought about Sjogren's syndrome as well. So we checked a rheumatoid factor that was greater than 850, and then checked a cryoglobulin screen, and that was positive.
And we'd like to know if people know why rheumatoid factors are positive in the context of cryoglobulins.
Ranking.
Cryoglobulins basically, there are three types of cryoglobulins. Cryoglobulins of type 1 are basically composed of is an IgM, usually monoclonal. Cryoglobulins type 2 usually is an IgG against an IgM. there are two types, IgG and IgM, and they are mixed. So one component is polyclonal, the other component is monoclonal. And type 3 cryoglobulins are also mixed, but both components are polyclonal. But basically, when you have a mix of IgMs and IgGs directed against one another, that's what a rheumatoid factor is. The fastest way to screen for the presence of a type 2 or type 3 cryoglobulin is by checking a rheumatoid factor. When a rheumatoid factor is negative, it's unlikely that a cryoglobulin is going to be present. So in this case, it was a very good thing that the team checked a rheumatoid factor, because what they were really measuring was the presence of cryoglobulins. Now, you need to now order a cryoglobulin immunofluorescence to know exactly which type of cryoglobulin you're dealing with. My hunch is that it's going to be a type 2 or type 3 cryoglobulin that are the ones that are most commonly associated with Sjogren's syndrome. I will also probably follow with serum protein electrophoresis and an immunoelectrophoresis to see if there is evidence of monoclonal expansion that will support the diagnosis of lymphoma for the mass we're seeing in the aorta.
Okay, great. So basically the SPEP and immunofixation were negative for any monoclonality. I don't believe she had I don't think she had the cryoglobulin immunofluorescence checked to determine the type. And let's see. And so I can tell you a little bit of some of the interval history that happened for her. So she was undergoing this workup, and she actually developed acute worsening of her abdominal pain. And so she had to have a repeat CT, and basically on the abdominal pain was so intense, and at this point it was radiating to her back. So they got a AAA protocol, and she had a ruptured infrarenal aortic aneurysm with irregular blood pooling in the aneurysm sac and dissecting through the intramural thrombus, concerning for basically like an impending rupture. So she underwent an endovascular aortic repair for the AAA. And because it was endovascular, we were not able to get any tissue sent since it wasn't an open procedure. And that's actually where I was, sort of on the consult service and started taking care of her. Someone's asking how big was her aorta initially. So the aortic aneurysm was 5.4 by 4.3. I'm not sure from the old CT what exactly was visualized before, but. So any thoughts now with this evolving AAA? We've talked about some of the labs and the cryoglobulins.
Well, it's unfortunate that tissue could not be obtained. I was hoping that was going to be the case, but basically the question is whether, and this is a common difficulty, whether in some other way, probably through CT interventional or some other approach, peri-aortic tissue could be obtained. I think it's going to be very complicated given that this patient was recently going through an intervention, but I always meet with the radiologist, sit down and see if there is any way to approach this peri-aortic tissue through a percutaneous biopsy so we can get an answer about what's the nature of the mass.
Han, any thoughts?
It's think it's spread because aortic dissection. I think maybe it's in the onset of circumstances, but the patient who has experienced the several weeks, so that his her boost positive in SSA and SSB may consistent with Trojan, and so this is I'm stuck go in the explain the cryoglobulin, and Dr. Angelo that helps me. The dream RF is quiet. Is it? I know that RF is have the role in prognosis of the worsen disease of vasculitis, and yes, and that's my thoughts.
Yeah, I think I had sort of a similar question as to, well, okay, because aortitis and Sjogren's was not really an association that I had not really an association that I considered in the past, and I'm just trying to think, like, is there something else? Is there a unifying diagnosis? Can Sjogren's technically can Sjogren's cause an aortitis? I haven't heard of it doing so.
The connection would be through the development of a lymphoma, I think. Okay. And that's and I think that's where what I would be concerned about, especially in someone who has an immunologically active Sjogren's, like somebody with a positive cryo screen with very low C4, very high titer rheumatoid factor. So this is someone who has whose lymphocytes are getting actively expanded. And it's true that the SPEP is negative. Sometimes the SPEP tells you if there's a positive monoclonal band, tells you that really there's a lymphoma in here. But we need to try to understand the nature of this mass, and that's how I would put the connection. Now we could continue working towards exploring this further, checking an IgG subclass. IgG subclass levels and see if there is elevated IgG4, but you run the risk of giving this patient too many diagnoses at some point. But I will be open to check an IgG subclass, and see if she has elevated IgG4. But at the end of the day, what is going to dominate is the possibility of obtaining tissue to figure out what's going on in that aorta. An MRI can also be helpful to look if there is inflammation of the vessel wall. An MRI of the abdominal aorta, or a PET scan is gonna be positive, because it's at this point the area is manipulated. So now I don't know if also with her graft it's possible to do an MRI of that area now. So.
Mm-hmm.
Yeah, I think those were all really good thoughts, Dr. Gaffo. And with Sjogren's, there are 2 points. We talked about this earlier, but thinking of the low C4 and a really high titer rheumatoid factor is like a poor man's screen for cryoglobulinemia. So if you see that pattern, it should prompt you to at least think about it. You can have hypocomplementemia from other causes with immune activation and lupus. It's not always associated with the cryos, but if you see the high RF and low C4, it's something to think about. And similarly, when you see like a low complements and cryos being positive, those are risk factors for associated malignancy with Sjogren's. I think that was another good teaching pearl. Her IgG subclasses, we did check, those were normal. And then, let's see. So we were in a similar sort of predicament at this point, trying to see how we could fit these pieces together, we thought about, could this be like a cryoglobulinic vasculitis with the rash and the proteinuria she had? But that shouldn't really cause large vessel inflammation and large vessel involvement. So we knew that that really couldn't explain the whole picture, and potentially, trying to figure out what was going on with the rash could give us at least a little bit of additional clues, since we couldn't get tissue from the aorta. But I'm happy to go ahead, Sean, if you think, and sort of tell what the next parts of her course were.
I definitely think you should tell the next part, because it's definitely, it's a game changer.
So interestingly, surgery basically gets routine perioperative blood cultures. And so those came back positive for Strep Pneumoniae in 2 out of 2 cultures. She never had a fever at home, or anytime during the admission. So at that point, with the cryoglobulins being positive, the blood cultures being positive, was thinking maybe this was endocarditis. And an associated aortitis. So she had a TTE that was negative. Her blood cultures cleared within 24 hours. So ID said, we really don't need to get a TEE. There's no way this is infective endocarditis. And so we were really unsure at that point, but assumed this was maybe an infectious aortitis. So Strep pneumoniae can cause an aortitis. And interestingly, there are some case reports where you can get cryoglobulinemic aortitis as sort of a manifestation of infection. So that's what we were debating at this point, and we really tried to convince her to undergo a skin biopsy to potentially give us a clue for what was going on there, but she basically declined a biopsy. Dermatology thought it was still probably shingles and reactivation in the setting of the bacteremia based on the appearance, even though the VZV PCR was negative. And then her thrombocytopenia actually kind of improved during the course of her hospitalization and normalized. She didn't have any, abnormalities on the peripheral smear, like giant platelets or clumping or anything to really explain that. So we thought that was possibly related to this infectious process. So now the big questions were whether the cryoglobulin and low complements were completely unrelated, which was a possibility, and she just had this, bacteremia, and because we checked all these labs, we sort of, came across the cryoglobulins and the complements. But we were thinking at this point it was either unrelated and potentially she has Sjogren's with, which can sometimes be associated with an asymptomatic cryoglobulinemia, or it was this cryoglobulinemic aortitis. So we actually had to sort of follow her outpatient, and after 6 weeks of antibiotics, her rheumatoid factor dropped from greater than 850 to 200. Her C4 went from less than 1 to normal 15. Her inflammatory markers, the CRP normalized SED rate after 6 weeks was almost normal in the mid 40s, and her cryoglobulin screen was negative. So that was really our supportive evidence that this was probably an infectious cryoglobulinemia. And we suspect she likely has Sjogren's syndrome because she had the ANA, positive SSA and SSB, and clinical symptoms of Zika symptoms with dry eyes and dry mouth. But it was a really interesting case because Dr. Gaffo mentioned these Sjogren's patients can have associated cryoglobulins, but in her case, we really thought, and the laboratory evidence sort of supported that this was an infectious cryoglobulinic aortitis. And so that was definitely a roller coaster of trying to sort of figure out what she had.
Very interesting. Thank you. But we have seen cases of aortitis caused by Salmonella more than once. So certainly it should be added to a differential of aortitis infections such as Salmonella or tuberculosis. So this is, I have never seen one with Strep pneumonia. But I'm not surprised by the fact that possibly was an infection. So it's very nice.
Mm. And I guess in terms of in terms of just sort of wrapping things up, Dr. Gaffo had mentioned aortitis possibly connecting with Sjogren's through the development of lymphoma. Any any biopsies that were done outpatient to try and work up if she had a non-Hodgkin lymphoma? Like, where would we biopsy?
I think you could consider a bone marrow biopsy. And sometimes when lymphomas are really hard to diagnose, like intravascular lymphomas, you can find them on skin biopsies. But usually you want to go where the mass is. But that's probably where I would go. This patient needs to continue to be monitored with SPEPs and IFEs probably.
Can I ask a question? Do we use a cryoglobulin screen for follow-up the treatment? I mean that her cryoglobulin is a return to normal. That's it. That means we have the right treatment.
We sometimes, when we treat cryoglobulinemia, usually once we detect the cryoglobulin, what we want to do is characterize it, and that's where you obtain a cryoglobulin IFE, and that will separate the cryoglobulins in whether there's IgM, IgG, and whether there is polyclonal or monoclonal. And you, based on what you find in that IFE, you can determine if it's a type 1 cryo, type 2 cryo, or type 3 cryo. And also we obtain a cryoglobulin crit. It's like a hematocrit, but you actually look at the percentage of the tube that is composed of cryoglobulin. So cryocrits, we call them. And when we treat cryoglobulinemia with, sometimes rituximab, steroids, or other medicines, we follow those cryocrits. And it should get better. It should go from a 10% cryocrit to a 2 or 1% cryocrit. In this case, what the team did was just in a more qualitative way. She went from positive to negative, so probably there was improvement. But yes, we follow the cryoglobulins. I saw a question from Dr. Estrada too. When should we think about cryoglobulinemia? Cryoglobulinemias usually are a small vessel vasculitis, and they usually tend to present with a rash, which is usually macular, papular, abdominal pain, glomerulonephritis, and in the context of diseases that are associated with cryoglobulinemia, like Sjogren's or lupus, or hepatitis C. So hepatitis C is very commonly associated with cryoglobulinemia, so you have to think about it then.
Yes, sir.
All right, great. Well, thank you guys. It was a really interesting discussion. So appreciate the discussants and Dr. Gaffo and allowing me to present today. So.
I definitely want to thank you, Mithu. I thought you did a great job and definitely appreciate you sharing this case with us.